Hello and welcome back. This week we're going to talk about trauma and stress-related disorders, and today specifically we'll talk about an integral model for combat PTSD. As you may know, since about 2001, we've had many years of ongoing wars, and over 1 million military personnel have served in Iraq, Afghanistan, and both. And the rate of PTSD in veterans appears to be around 15% or even more. And we have hundreds of thousands of veterans that are using VA services. So certainly many of these folks have met criteria for PTSD, which, as you'll see in the DSM, which is under the category of trauma and stress-related disorders, post-traumatic stress disorder. It involves exposure to actual or threatened death, serious injury, sexual violence in one or more of the following ways: direct experiencing the traumatic event, witnessing in person, learning about the traumatic events happening, experiencing repeated or extreme exposure to adverse details of the traumatic events, like first responders, and that, these don't apply to exposure through media, but things that are, more real, that actually happen, and certainly combat PTSD in veterans occurs as a result of this kind of exposure, sometimes repeated exposure. PTSD used to be considered an anxiety disorder, and it can occur following any traumatic, life-threatening event. Individuals re-experience the event. They may avoid situations that remind them of the event. They may feel numb. Dissociation is a main symptom. They also have hyperarousal, and it lasts, for several weeks. So it lasts for more than 4 weeks. So a distinguishing factor between an acute stress disorder and a diagnosis of PTSD is really the length of time, where an acute stress disorder is a reaction that may last anywhere from 3 days to a month. If it's more than a month, then it can meet criteria for diagnosis of PTSD. For many of the combat veterans, there are other differential diagnoses and overlapping diagnoses and symptoms that may occur. For example, many combat veterans also experience traumatic brain injury, or TBI. There's many physical, cognitive, and emotional symptoms that may follow a concussion that overlap and also react, that are reactions to trauma, that overlap with reactions to trauma. So also a traumatic brain injury is caused by trauma. Many individuals that are veterans that have been in combat may have been involved in an explosion that led to a traumatic brain injury, and also was the traumatic event that may have led to their PTSD. So TBI is caused by trauma, and many who get a traumatic brain injury may also develop PTSD. So it's really something to look out for. And it's important to assess traumatic brain injuries because of medications and also counterindications of the effects. There's other problems that occur with PTSD. Drinking or drug use, feelings of hopelessness, shame, despair, employment problems. Certainly we see a lot of underemployed or unemployed veterans. Relationship problems, including divorce and violence, and physical symptoms. So if you think about the integral model that we had discussed, these other issues with PTSD go beyond just the I, the individual, but overlap and bleed into all four quadrants. And so we'll talk about Wilber's integral model and looking at the four quadrants and how PTSD, as experienced by combat veterans, can bleed into all four quadrants. Today we will be using a specific example of a combat veteran in a case of somebody with PTSD. So if you recall Wilber's integral model, the four quadrants were broken down into the pronouns of I, it, we, and its. So with the top half representing the individual and the bottom half representing the collective, the left representing the interior and the right representing the exterior. And Wilber's AQAL model looks at all quadrants and all lines of development. It describes 5 irreducible aspects of human development. So you have the quadrants, which are the 4 domains or perspectives. You have the lines, which are multiple intelligences or aptitudes, and there may be over 20 of these. You also have levels, which are stages of development. States, which are aspects of consciousness, and different types, like the Myers-Briggs personality typology, types such as male, female, and so on. So they look at these aspects of human development and integrate them into a holistic model in which you can assess an individual. So in terms of looking at a 4-quadrant assessment of a client, if you're looking at the upper left quadrant, the I quadrant, this is the conscious subjective. You have things such as self-concept, mood, thoughts, images, memories, or any kind of patterns of self-experience, self-expression in that quadrant. If you now move to the upper right, the it quadrant, this is the behavioral. This is the objective quadrant. These are things that are observable, measurable, like your health status, genetic predispositions, substance use, your medications, your sleep, your actual diet, and patterns of behavior that are observable. Moving down to the lower left quadrant, in the we quadrant, the cultural quadrant, this is the intersubjective, has to do with culture and worldview. Here we have the cultural and ethnic values and the identity of an individual. We also have family values, gender roles, intimate relationships, the family system, sexual identity, religious, spiritual beliefs, political beliefs, fall into this cultural and worldview. And then finally, the 4th quadrant, this is the lower right quadrant, the its quadrant. This is the social system, environmental, and this is the inner objective. So here we have socioeconomic status, people's access to health and legal systems, home environment, work environment, their natural environment. So looking at these broader ecosystems, these broader social systems, and how they interact with each other. When you think about the lines of development, there's multiple lines of development. We'll just go over a few, and then there's some key theorists. Some of them are psychologists, some are other philosophers and key theorists, scientists, researchers that are noted in making contributions in this area. So for example, the cognitive line of development, the life's question that it asks is, what am I aware of? And theorists like Keegan and Piaget are noted for research in that area. The self line asks, who am I? And theorists like Loevinger are noted in that area. The line of values asks, what is significant to me? We have here theories of spiral dynamics and Graves. The moral line of development asks, what should I do in this situation? And we have theorists like Kohlberg. The interpersonal lines is, how should we interact? We have the spiritual line of development, asking what is of ultimate concern to me. The needs line, which asks, what do I need? You may be familiar with Maslow's hierarchy of needs. That comes from the needs line of development. There's also a kinesthetic line of development, which is, how do I physically do this? If something changes with your body, how do you then physically do what you used to be able to do? There's an emotional line of development, which asks, how do I feel about this? And an aesthetic line of development, which is, what is attractive to me? What is considered beautiful? What is considered attractive? All of these and then others are very important. And so when you think about where somebody is in their level of development, and how something like trauma impacts an area, a line of development, one of these developmental lines, it's not just one area that may be impacted. It may be different areas at different stages. So what you end up with is a psychograph. You end up with this kind of a profile of an individual where they may be high on one level of development and maybe lower on another level of development. Or an incident like a traumatic event may impact one area more than another, or it may impact many areas at different rates. And so the integral model, the way it interacts with psychology, is that it really incorporates all schools of psychology into a holistic context, which is called integral psychology. It allows therapists to take an integrally informed approach to their discipline, and we'll learn about the integral intake and how to use it with a client in the second part of this course. And also the AQAL model, all-quadrant online model, allows therapists to apply methodological pluralism to the treatment of their clients, so you don't have to utilize just one theoretical approach. So now I'd like to talk about an integral conceptualization of PTSD and how the experience of a trauma and the actual symptoms of PTSD and a diagnosis of PTSD is present not just in one quadrant, but really in all of these quadrants. There's the emotional, self and personality of the I quadrant, the physical, nervous system and biology of the id quadrant, the family culture and how communication is impacted in the we quadrant, and also how institutions and environments are impacted and interact with all of this in the its quadrant. So in thinking about combat PTSD, or trauma incurred in combat, we can look starting with the I quadrant. So if you have an individual who's experienced wartime combat PTSD and meets criteria for PTSD, that individual may have some symptoms, some issues that are involved in the I quadrant. This would be chronic arousal and dysregulation of emotions. This is their subjective experience. They may feel helpless, ineffective. They may be expressing irritability and anger, shame, despair, depression, disinterest, a feeling of disconnection. They may feel like they're permanently damaged because of not only the trauma, but their now emotional response to it. And their sense of self. They may have a change in previous personality characteristics and also feel constantly threatened. So this is that kind of chronic arousal that dysregulates emotion and their sense of self. In the id quadrant, these are more observable behaviors that result from PTSD. You have the traumatic exposure, which can lead to lasting alterations in the endocrine, autonomic, and central nervous systems. So this kind of traumatic exposure can actually make changes in your cortisol level. So there's a change in cortisol level with people that are living with PTSD. There's increases in neurotransmitters like glutamate associated with affect regulation and low levels of serotonin. There's also decreased activation in the medial prefrontal cortex in individuals with PTSD, and that's associated with inner sensation and perception. The effects of trauma on the autonomic nervous system are also notable. There's sympathetic overactivation and also parasympathetic overactivation. In terms of sympathetic overactivation, trauma can impact the sympathetic nervous system by inducing hyperarousal, hyperactivity, hypervigilance, constriction, panic, and anxiety. And also, there may be parasympathetic overactivation where the opposite may happen. It can stimulate a sense of disconnection, depression, exhaustion, numbness, and disinterest. And in fact, both the parasympathetic and the sympathetic nervous system can be overactivated as an effect of trauma. And there you have that freeze effect, that kind of deer in headlights freeze effect, where dissociation may occur. When you have both the parasympathetic and sympathetic nervous system overactivated, you get that freeze response, a potential dissociation, and a diminished awareness of fear and pain. Some people have talked about how in the wake of a traumatic experience, when they're actually going through it, they don't even feel the pain. They're not even aware of what's going on. It's this diminished awareness. There may be a dissociation of it going on as well. Now, we talked about dissociation, and many have talked about dissociation as being one of the key symptoms of trauma and an important predictor of PTSD. Now, in the DSM, there's a separate category now of dissociative disorders, but dissociation is actually a key feature of PTSD as well. The dissociative state is like a causal witness state, but instead it's used as a defense mechanism, and it's not integrated, it's not transcendental, but it's a dysfunctional attempt to transcend that doesn't add to one's spiritual growth. So the type of dissociation that occurs in response to trauma is not anything like a transcendental state, but it's really an attempt to escape that doesn't add to anybody's spiritual growth, according to some theorists that talk about dissociative states and PTSD. So moving down to the we quadrant, individuals with PTSD have difficulty making meaning of the trauma, and individuals that have been involved in combat-related trauma have difficulty making meaning of their involvement in combat. They may have a strong identification with military culture. We see this a lot with veterans. Many of them really identify with that military culture. It's like a family to them. And they may also have family and peer expectations. They have difficulties with interpersonal relationships. If your sympathetic and parasympathetic nervous systems get overstimulated, that injury does not just stay in that upper right quadrant, in that kind of behavioral biological quadrant. If your nervous system is wreaking havoc, then it ends up bleeding into, metaphorically, bleeding into other areas of your life, like your interpersonal relationships. You may have a sense of detachment. It's very difficult to communicate clearly with your partner, with your loved one, with your family, when you're feeling flooded. Some of these veterans describe feeling flooded when inevitable conflict occurs in their family life, when they go back to their spouses, they go back to their families, and inevitable conflict occurs in their home life, in their marital life, and they're just really intolerant of this conflict. They can't handle it, and their partners may not understand, their family may not understand. Why can't he or she just have a normal discussion anymore? I can't talk to him. I can't talk to her about anything anymore. A lot of it may have to do with this overstimulation of their nervous system, really injuring their ability to be able to stay present during an inevitable conflict, an inevitable discussion that occurs in family life. Moving now to the ITS quadrant, the experience of PTSD is not just seen individually or biologically or behaviorally or even within the culture of the family. It's really seen through society. Individuals that are veterans that have combat PTSD have issues with access to health and mental health resources. There's institutional demands. Social awareness and education that needs to go on. There's issues of violence in the media. They may be triggered by seeing violence in the media. There's also issues of education and retraining. There's more and more universities that are seeing veterans coming back to be retrained, that are discharged for multiple reasons from the military and then using their GI Bill to go back to school, or veterans that have been injured, been discharged for medical reasons, now going back to school and having to find new careers. So I'd like to talk about a case example. This is actually a case that a dear friend and colleague of mine had seen at the VA hospital in San Diego. And we've discussed this case in an integral framework, presented on it before, utilizing an integral model to describe combat PTSD. So we'll call this young man Gary. This young man is a Caucasian American male. He's 25 years old. He's married, and he was a medic in the Marines. So he was a medic. He was a first responder. He was the leader of his unit, and what had happened was during one of his deployments, he was traveling with his unit, and their Humvee went over an explosive device. It exploded. It exploded their vehicle, and many people in the vehicle were injured, including Gary. But Gary was actually the medic. So what had happened was the blast injured both of his legs severely, and he had experienced this stimulation at the time where he wasn't even aware. He was trying to scramble to help others, and somebody had to wrestle him down to the ground because his legs were completely blown apart, mutilated, destroyed, and once he was stabilized, brought to the hospital, he ended up having to have one of his legs be amputated because the injuries were so severe that he had one of his legs amputated. The other one was severely injured, but was able to be treated and salvaged, but one of his legs did have to be amputated. So in his situation, he had planned on having a career with the military. He came from a military family. His father had been in the military. His grandfather had been in the military. He was very proud to be a Marine. He had had multiple deployments and was very proud to serve as a medic in his unit. After his leg was amputated, he not only experienced the difficulty of losing a limb, but he continued to have what we call phantom limb pain. This is where the mind, your brain, and really your mind does not integrate the information that the limb is gone and that there's no limb there, but still registers pain from that area that was injured during the blast. So he was experiencing pain in a part of his leg that had been amputated, and this is known as phantom limb pain. He had presented at the VA hospital in San Diego. He was actually part of a research study there looking at treatments for phantom limb pain. he had gotten psychotherapy. There were other opportunities for other treatments for phantom limb pain. But when you look at his experience in the integral model, you look at what part of his experience goes into which quadrant. You could follow along on the slides that I've sent you in the integral case conceptualization of Gary. In the I quadrant, you have his identity, that he was a medic, a leader of his unit. You have depression that he experienced. You have the actual many of the symptoms of PTSD, the anxiety. So he actually did meet criteria for PTSD through re-experiencing, through having nightmares, through a lot of the anxiety that came with it. He actually met criteria for PTSD. Along with that, he also was a perfectionist. This was somebody who was used to doing things very well. He had some existential issues as well. He had survivor guilt, that he survived the blast where several of his fellow Marines did not that day. They died as a result. There were a few men that day that died, and even though he ended up with a severe injury resulting in amputation, he did survive the blast. So he had this existential crisis and survivor guilt, that why was he better than anybody else? Why did he live and they end up dying as a result of this blast? He had a really changed sense of self and identity. He considered himself damaged goods, and really had this rebellion now about how he viewed life, how he viewed the military, and all of that was that sort of conscious, subjective sense of self, of which some of the symptoms of PTSD were only part of. Now, if you look at the IT quadrant, you looked at that objective quadrant. He was 25 years old. He had witnessed violence and a lot of ambiguity through his multiple deployments. So even though the traumatic event that resulted in his leg amputation happened during the last incident in his last deployment, he had witnessed ongoing violence. He also experienced a traumatic brain injury. He had a serious brain injury during that blast. It resulted not only in the injury of his leg, but also he had hit his head very hard during that blast. His head was injured, resulting in a traumatic brain injury. His leg was amputated. He experienced phantom limb pain. He also experienced cognitive symptoms, like some memory delay. Sometimes he would even forget to come to his appointments on time, so he had experienced memory symptoms. He felt slowed down, fatigued, and the symptoms that go into a diagnosis of PTSD, of re-experiencing, also go into that IT quadrant. If you move now to the lower left, the we, the cultural, intersubjective, Gary identified as a Marine. He had multiple deployments. He had now been separated from his unit. He was, forced, because of his severe injury, to leave the Marines and sent back home and put on an assignment at a desk job, which he was not happy with. He had been separated from his unit. This was not an expected turn of events for him. He also had family of origin issues of his own. He was married with a child. He was having difficulties now with his wife, kind of reintegrating back into family life, and also having difficulties about his identity. He came from a family of Marines. He was having difficulty sort of differentiating and living his own life. Now that he was no longer going to be, you know, in the line of duty, going on deployments, working as a medic, or doing that physical kind of a job, that he was no longer able to do that, what was he going to do with his life? So he really was having some issues with the social support, including issues with his father, issues with his wife, and trying to kind of figure out what his new worldview was, what meaning he gave to his life. What did this war mean? Why did he end up getting blown up, years ago, in a Humvee in Iraq? Why was he there anyway? So he was really questioning all of this. Was it all worth it? Why did his fellow Marines have to die? So he was really kind of questioning his worldview. And moving to the lower right quadrant, the ITS quadrant, the social intersubjective, you now have an individual with disability status. And he was very dissatisfied with his new position. He was really wanting public understanding and political understanding about the war. He wrote multiple letters to the president after all of this happened, stating his dissatisfaction with the war, saying how, as a Marine now, he was protesting the continued presence in Iraq and Afghanistan. He felt that nobody really understood his situation. He felt like he was very alone in some ways. And he also now was going to be in need of re-education. One thing that he had talked about with his therapist was going back to school. And he actually contemplated becoming a counselor or a psychologist because of the experiences that he had had through therapy. So this is somebody that was going to be presenting to the education system for higher education, for re-education. He no longer wanted to pursue a career as a medic, wanted to do something where he would be able to continue working with his disability and really was exploring different avenues for higher education. So as you could see, Gary had a lot of questions along these lines of development that he now had to answer that he didn't have to think about before. For example, he had to now reevaluate what is significant to me. How do I feel about this situation? What's of ultimate concern? What should he now do? He had to ask, who am I? And really, at a very basic level, how do I physically do this? When, after having a leg amputated and having a prosthetic leg, how does he now do the things that he used to like to do? He was a very active person. And what do I need? What do I need, to have my needs met at this point? So we can take a look at Gary's lines of development, his cognitive, emotional, interpersonal, self-values, and spiritual. On his cognitive line of development, Gary was having some issues with his memory. So he had a traumatic brain injury as well as PTSD, both of which can impact your cognitive development. Depression can certainly slow down your processing speed and the way that you process information. Traumatic brain injury can also impact cognitive abilities such as memory. On the emotional line of development, Gary was also experiencing depression. He had actually met criteria for a major depressive episode. We'll learn more about mood disorders in the following week segments. But as we learn, many individuals that meet criteria for one disorder may also meet criteria for another disorder. And in this case, Gary was also having issues on the emotional, in the emotional area of development. Interpersonally, he was having, some difficulties with his wife and kids. And in the area of self, this is where, you can look existentially about who is he now? He had identified for so long as a Marine. And so he now had to think about, where is he on his level of self-development? How is he going to grow in level of self-development? And in that sense, this kind of an incident, this traumatic incident, allowed for change to occur in self-development and development of values and spirituality. He now was shaken up, literally blown up. His life was blown apart. His leg was blown off, completely shattered, and his sense of self, values, and spirituality, meaning of the world, was now shaken up, blown. And in a sense, this incident allowed for some growth and some change to occur. Whereas, unfortunately, he had some difficulties in other areas. His sense of self, values, and spirituality were at a place where they could develop, and he was now actually paying more attention to those areas, as instead of continuing his life on autopilot in an area where he felt like that's who he was. He was, the Marine, he was the medic, he was this active, physical young guy. When that was blown apart, it really caused him to focus on these other lines and areas of development. And so we see that healing from trauma depends on the communalization of the trauma, being able to safely tell the story to someone who is listening and can be trusted to retell it truthfully to others in the community. So before analyzing and classifying, before thinking, before trying to do anything else, we should listen. Categories and classifications play a large role in institutions of mental health for veterans, in the education of mental health professionals, and as tentative guides to perception. But all too often, however, our mode of listening deteriorates into intellectual sorting, with the professional grabbing the veteran's words from the air and sticking them into mental bins. Listening in that way destroys trust. This is a quote from Jonathan Shea in 2002, talking about the need for an integrative understanding and healing from trauma. And so in this way, I'd like to leave you to then think about the integrative treatment of PTSD. We've seen now how in 4 quadrants of what we think about in just one kind of a dimension, we think about the diagnosis of PTSD or the experience of a trauma, how it could be assessed and looked at in 4 quadrants and multiple lines and levels of development. I'll leave you to look over the slides on the integrative treatment of PTSD. But for the purposes of this course, we're going to focus more on the assessment and diagnosis. Okay, thank you for now.